Okay, so once the marking is done, then the fluoro back up, and then this patient is prepped. Then we drape the patient with the lumbar laminectomy or discectomy drape, usually called laminectomy drape. We put the drape on, and we go drape the C-arm also, and then the surgeon can come and do the operation. Now, in order to put uh, the patient on this bed, on this special frame, Wilson frame, normally we need 3 people to 4 people. Anesthesia takes care of the head. One person goes to the leg, and one person on the left side and one person on the right side to roll the to actually not roll, to lift the person up from the bed, like a cart or patient cart or patient bed, where they're anesthetized. The anesthetized patient is then moved from the regular bed to this Wilson frame. So the patient is usually coming to the OR on a cart, supine. Anesthesia do their work, and they induce the anesthesia. The patient becomes unconscious and paralyzed. That is when 4 persons comes, and all these help, they turn the patient to the prone and put them on top of this Wilson frame. Literally, one person who's responsible for putting him on the frame uh, uh, uses both hand, goes under the belly and lift the person up, and then move it from the cart to the frame. This is a very careful transfer of the patient from the cart to this frame. Surgeon usually makes sure that the patient is positioned optimally to have an exposure to the surgical area, right, wherever they're performing. If they're performing lumbar 4, lumbar 5, lumbar S1, then they're working around this area. Uh, so they drape it accordingly. So this is good for thoracic and lumbar laminectomy surgery. Wilson frame. We also have another bed, which is called Hall surgical bed, uh, that is part of the part of the specialized procedures. So the visibility and hemostasis. This is about when they're doing the procedure, they require exposure of the site, and also they need to maintain hemostasis. So they use irrigation uh, with the sodium chloride, like saline irrigation at room temperature, using the Acceptor bolsterings that we have. And we have the suction that we talked about, Fraser tip or Adson tip. Those are the suction tip that the surgeon can maintain the suctioning ability by touching there's a hole in the Fraser suction tip. By blocking that hole totally or partially, they can manage the suction usage. Then we have bipolar forceps that we talked about, used very routinely for neurosurgery. And also Bovi can be used on the skin and on the, or if they're doing surgery on the brain, they can use the Bovi and the cautery on the scalp to coagulate the bleeders. We have Rene clips that can be used on the scalp as well as the Bovi. We have numerous hemostatic agents. For bone, when they take the bone by with the kerosene punches, the bone can bleed, and bone wax is used on a pen-filled dissector and can be applied directly to the bone bleeder. Then we have cotton patties. They are usually moistened with a saline solution, and that can be used as a tamponade. Then scalp edges, then I told you about, we can use a Rene clip, a scalp clip during the craniotomy procedures. Those the Rene clips are automatic, the guns are automatic, so they're like our stapler. They can use as many clips they need in order to prevent any kind of bleeding during the scalp dissections. Other methods of controlling the bleeding, we have Avitin powder. Uh, as you have seen, the Avitin powder is used for GYN procedures, and also for plastic surgery, they use the Avitin powder. So it's a microfibrillar collagen. It bonds by forming fibrin. And we have gelatin sponges, which are gel foam. Gel foam can be moistened with saline or topical thrombin. And the sizes are determined along with the patty size, 1/4 quarter inches or 1 inches or half inches by half inches. Different sizes, those are available. Uh, you make it available on a little petri dish or maybe a cup that you can use to have all these gel foam pre-cut, ready to go when they need to use it, apply it on the bleeder. Laser, they may use laser for controlling bleeding. The draping procedures are usually towel drape, which is could be a disposable paper material, or it could be a linen cloth towel to outline, to square up the incision area. Uh, and then when they're using it on the head, sometimes they use it to staple, or they use a suture material to attach it to the scalp because of the location. Otherwise, the towel will just fall off. Whereas you can imagine the head will be positioned on the, let me show you, on the headrest. And if you want to put towel around this area, because of the area location and the way the head is positioned, unless you staple it to the skin, the towel will fall off. That is why you pass the towel along with the staple gun, skin stapler, to attach the towel to the scalp. And then we provide the drape, either the craniotomy drape or a neurocraniotomy drape. They come in the pack for head procedures. or we can use laminectomy drape for lap sheet or laminectomy drape for laminectomy procedures, so the lumbar area or thoracic area. Then we also have C-arm drape, microscope drape. Those also come in uh, uh, as a part of our stereo supplies. The craniotomy incisions are very special because they take sometimes they can take for a flap they can use the craniotomy drill bits, the craniotomy, and the perforator is a disposable drill bit that can be available. That you can load it on a high-speed craniotomy, and then use a side cutter, replace that with a side cutter, and then take a nice bone flap uh, on top, usually underneath there, the area where they're going to uh, uh, perform the surgery, the procedure, actual procedure. If there is a hematoma there, or if there's a tumor there underneath, they can remove that after they take the bone flap. This bone flap, they take it and they give it to the surgical technologist, and the surgical technologists use a moist lap and preserve it, store it on the back table, because this flap will be needed back when they're closing the area, closing the scalp, the incision again. Uh, they can do acoustic neuroma resection. They can do intracranial aneurysm clipping, uh, malformations of the arterial venous malformation surgery, or they can do also work to do other problem associated with the brain. And they can do frontal, parietal, occipital, or temporal. All of these bone flaps can be taken. As you can see in this picture here, the scalp is incised, and there is a flap, a C-shaped flap has been taken. And the edges, the bleeder, there is highly vascular area, so it bleeds right as soon as the surgeon incises. So this blue clip that you see, those are the Rene clip. They control bleeding by compressing the bleeders around the edges of this flap. Now, after the flap is taken, this is what underneath there, the cranium, the periosteum. There is a periosteum structure that has been lifted by using periosteal elevator, and then this bone flap is taken by using saw blade and the perforator drill bit. Now here you're seeing the closing of the flap. Back up, the bone flap went back in. The underneath the brain tissue has been repaired. The procedure what is required has been done. Irrigation's been done, and then they sutured the dura material. This is the dura they're seeing. This dura has to be open and then tagged. During the closure, they close the dura back up with a silk suture. Then they put the flap back on, and they can have a cranial plate designed for craniotomy surgery, designed for bone flap of the cranium. And these tiny little plates, titanium plates and titanium screws, self-drilling, self-tapping screw. So these screws do not need any drill. You put the plate on, and you can put the screw on by using the screwdriver. The sizes are also predetermined. The length of the screw, diameter of the screws are also, they come in a different assorted sizes on the tray. So they open these TIMES system or any other system that is available to put the flap, the bone flap back on. Then on top of the bone flap, they put a gel foam or other material, cellulose material, to give to cover certain defect that may produced by the flap. Usually the defects are come like a drill hole around this area. The perforator made that drill hole. Those cannot be repaired. They can be repaired by a round plate, but also can be covered with a patch of this type of material, Teflon or other material, choice of the surgeon. That is a very serious joke. Thou shall not drop the bone flap. If you drop the bone flap, you can imagine there is nothing to replace that bone flap. So you have to be very, very seriously careful. As soon as they give you the bone flap, take it with both hands, using total attention to the bone flap transfer from the surgeon to you, and then you preserve it, moist lap, and preserve the bone flap on the back table where it won't be damaged, or it won't be you're not going to, do not put it on the corner or edges of the back table. Always keep it in the center of the back table, the central area. Usually in the middle of the back table, you find a nice space for the bone flap, and that is where you keep it. Do not move it. Do not do any kind of movement with the bone flap, so you may lose it. So be careful with the bone flap. Otherwise, you can understand what may have problem with. These are craniotomy for some examples. As you can see here, left-sided craniotomy was done on this patient. The whole area of the temporal lobe, temporal area, bone, and part of the parietal bone and part of the frontal bone the whole flap has been removed. So this has been done for evacuation of intraparenchymal parenchymal hemorrhage of the left frontal and left temporal region. The scalp muscle first has to be incised. They make a marking. They use a marking pen. After the shaving is done, the hair has to be restored. Then the prepping is done for this area, and then when they go in for the flap, the surgeon usually makes the marking with a marking pen, and then they take the scalpel blade, number 10 scalpel, and then incise it through the scalp. The scalp muscle, as soon as it's been incised, they need a Rene clip to put on the both edges of the scalp to control bleeding. Then there is muscle has to be split open. The scalp muscle has to be split open in order to go to the cranium. Periosteum has to be stripped with the periosteal elevator. Then the burr holes are made. These little holes are made with the burr hole perforator. High-speed drill like Midas Rex, OnSpark, or craniotomy striker drills are used for high-speed drilling with the perforator. That makes a drill hole through the cranium. Those perforator has a special design. They I have shown you during the instrumentation for neurosurgery before. Those perforator have a stopper. So they go in, as soon as they go in on the other side of the bone, and if they find as soon as it reaches the soft tissue material, a dura, it stops. So as soon as there is no resistance of the bone, the perforator stops. So there is no way to damage the underneath the dura or underneath the bone by over drilling. That is a very safety mechanism that is built into it with the perforator. The perforator are specially designed for craniotomy drill hole. Then after the perforator is done the drill hole a couple of areas like 1, 2, 3 areas, then they change that perforator to a side cutter. The side cutter is designed to cut through the cranium. Then they make the surgeon makes the cut slowly through one hole to another hole, and then finishes the cut. And after the cut is done, this bone flap will be lifted. For this kind of incisions, the bone flap is restored here because the muscle that you see, this muscle will be still attached to this type of incision, this type of C incisions, the question mark incisions for the temporal region. Here, the bone flap will not be given to the surgical technologist back, but it has to be restored very carefully with a moist slab around inferior edge of the bone, the flap. Underneath there is a dura. That dura is now exposed. That dura has to be open. When they open the dura, they use silk suture or other form of suture to retract it. So when the dura is open, then you actually have access to the brain area. If there is a parenchymal evacuation of hematoma, then you see the blood and the exposure is there to do the surgery. So they use suction, Fraser's suction or aspirator, to remove this hemorrhage and to complete by irrigating that area. And then once they are sure there is no hemorrhage, hemorrhagic tissue are available or present there, then they turn the flap back on, use those type of plate, tie mesh or craniotomy plate, and put the and secure the flap back to the cranium, and then they close the scalp by removing. They take the Rene clip remover, and then they using that Rene clip remover, they take each one of these clips and give, and the bleeding, they check for hemostasis. Once they are sure there is a hemostasis has been achieved, then they close back on with the choice of surgeon's suture of choice. Ovicral or tubicral, they want interrupted suture and technique, and they close this C mark incisions of the scalp. That is the one type of surgery that has been given as an example here, craniotomy for parenchymal, intraparenchymal hemorrhage. So hemorrhage has been removed and controlled after this craniotomy was performed. So what is going on with the craniotomy? So incision was made through the skin and the galea. Galea is a layer of periosteum, and that layer is incised. Then the scalp clips were applied to the flap edges. Periosteum, or that's the structure that is adjacent to the bone, is stripped, and then the bone wax was used to control the bleeder coming from the bone edge. Burr holes then was drilled with the perforator of a craniotomy. Then the burr then has to be during the burr hole procedure. Uh, there has to be the burr, then the whole area has to be irrigated with sterile water to prevent clogging of the burr and keep the bone area cool. Otherwise, the heat may generate. And once the burr hole is done and then the flap is turned, then we have dura mater freed with a finfold dissector or dura separator. Uh, uh, like here, as you can see, the dura is exposed here. Dura is incised and then it is turned as a traction is made, and then the underneath the structure is exposed. So dura separator is used for freeing up the dura mater. Uh, so to continue, so to continue after the surgery is done, uh, the bone flap, as I said, it has to be wrapped with a moist slab with the antibiotic solution and secured on the bone back table if the bone flap is removed. If the bone flap is just turned and left there, then the lap sponges and antibiotic solution soaked lap sponges are given to the surgeon to kind of wrap the bone flap there on the field. Uh, so dura mater has to be lifted using dura hook. The dura hook is special design instruments to lift up the dura mater, and then the surgeon then holds it with a dura pickup and Metzenbaum or Jamison tenotomy scissors. Then the brain is exposed, and then it is retractors, handheld retractors, or self-retaining retractors that we have seen before. Those are used to retract that area. After the procedure is completed with irrigations and drainage of the hematoma and hemorrhage, uh, they close the dura back with the foro neurolon pop-up and RB1 needle. This is the neurolon is a suture of choice for the dura repair. The cranial bone plates and then the screws can be used to secure the bone flaps that we have seen that they use. Let's see, we have shown you before that those plates that were used. This plates, this tiny little plates, and they come in many different shapes. They can be square, they can be like this, two hole, they can be multiple hole like a circular plate with a 6-hole on it. Depending on what the surgeon needs, they use either multiple 2-hole plate or multiple 4-hole plates, whatever they require. Uh, so this is what they do for bone when they are turning the flap back on, putting the flap back to the cranium. Now for retractor wise, we have seen use of uh, this retractor, Lila retractor. This is a retractor that goes on this railing of the bed, of the OR table, not the bed, OR table. And then the spatula, uh, they could be of many different shape and sizes, narrow, wide, wider size. So, they use it, whatever they think is necessary. They can assemble that Lila plate, the plate to this flexible hand of the Lila retractor, attach it, and so once it is at all these the areas, the screws are being tightened, this holds it in place during the surgery. If they need to change the angle or change the positions, they come in and they undo these the screws, and they find a new position, and that's where they attach it again. So it helps to retract without having to hold a handheld retractor. So that's our retractor. We have many different self-retaining retractor. That is one example of a self-retaining retractor, what they need in order to do procedures like craniotomy. So craniotomy starts with the skin, scalp, gallia mater, the periosteum, then the perforator. Then you see the bone flap is taken off. Underneath the bone flap, dura has to be removed. Then dura is not removed, dura is incised, and then the brain is exposed, and then they perform the procedures, whatever procedures they're intended to do. If they have to do a tumor resections, they go in with the CUSA, cavitron ultrasonic aspirator, or if they're performing hemorrhagic tissue excision, removal of hemorrhagic tissue, they use suction tip and bipolar forceps to remove the hemorrhagic area. Then after that, they provide the irrigations, and then they uh, use the plate and screws and suture of Neurolon and Vicryl to close the craniotomy flap. So we may also see cerebral aneurysm, like we told you about the aneurysm that you're seeing here is a ruptured aneurysm. This is basically an artery that is been shown here, and the branch, and that's where the wall has a weakening, and this area had a sac-like structure. That's where the blood was contained by the layers of the artery, tunica intima, tunica media, and tunica adventita. When this area, those layers erupt, let the aneurysm rupture, then the bleeding is a big problem. Now there is a lot of things they can do to prevent the bleeding to continue. One they can do is a coiling. This is a coiling they can pass through the artery, and then they can have this coiling work like a plug, aneurysm plug. They sit through the narrow opening of the artery. Here we're looking at middle cerebral artery. For some reason, this artery causes a lot of aneurysm problem. So the coil is been advanced, and the taken off the area, and it works like a plug. Now this aneurysm that we're seeing here on the left side, it has not been ruptured. So that is why the coiling can be done to achieve the therapy for the aneurysm. Whereas if you have a ruptured aneurysm or aneurysm that is about to rupture, very weak artery wall, that's where the choice is to put a clip, permanent clip. The clips are manufactured by the esophageal. We call them esophageal clip. We have many other type of clip, but this is clips. Is esophageal clips are very it's been used for a while, many years now, and they have a lot of different sizes and lengths, and the angle is different. Some of them are curved, some of them are like straight like this, and these clips are very delicate. Uh, uh, they also come with a clip applier, esophageal clip applier. They look like a Castrovio needle holder, but instead of needle, they grab this area of the clip. The surgical technologist very carefully uh, applies that esophageal clip applier, and bring the clip out of the clip box. They come in a the box assorted with different size, different length of a esophageal clip. The surgeon will say, give me a size 2 curve or size 2 straight clip, and they go in there and look for that particular clip, and they take out that clip and load it on the esophageal clip applier. That clip applier with the clip then is given carefully to the surgeon. Uh, Surgeon then takes a really careful measure to apply this clip right at the base of the artery. And once the clip is done, they leave the clip there permanently. So there is a way of treating cerebral aneurysm. Uh, Aneurysm surgery is fascinating and it's very intriguing surgery. It takes some time depending on the structure they're clipping. It takes a few hours sometimes. So during that time of clipping, the OR usually goes into a silent mode. That means they take off all the phone call, incoming phone call, and they stop incoming. Let the front desk know they are going to clip. They don't allow any more traffic through that OR, because this is a serious moment when they apply the clip. If accidentally they damage the artery, nearby artery or nearby nerve, that could cause a life-threatening situation. In order to avoid that, surgeon and the team takes the ultimate precaution. So everybody is very careful about when the clip application process is going on. Anesthesia usually reduces the pressure by giving nitroprusside drop, or they give mannitol to reduce the pressure of the brain, and the other medication they can give in order to reduce the blood pressure, drop the blood pressure quite a bit to allow this area to clip. Sometimes they perform carotid artery access, and they leave that access on just in case there is a bleeding. They can go to the carotid artery and uh, retract it by using vessel loops or umbilical tape to partially close the blood flow to the brain area. So this is a big operation, and it takes time and effort to set up for these kind of cases. Uh, so it's if you get a chance to observe, feel free to don't let it go. Take that mm, opportunity and watch the whole case. See how delicately they perform this kind of operation. The scissor that we talked about, Jamison tenotomy scissor, look like this, and the point is very blunt but sharp. Blunt means the outside edges are blunt, but the cutting edge is very sharp, and it can be used along with the Metzenbaum scissors to incise through the dura mater. Let us stop at this time and let's take your break. We come back and we're going to revise some bone plating. Uh, so let's take a little break, okay? Do you have any questions?
No.
No.
Okay, good, good. Let's take a break and come back and we will go through the rest of this chapter here.
Okay.
Okay, folks. So let's talk about bone plating. Uh, these are the bone plates that I discussed. These are manufactured by Time-ish company, and also you can find other companies are manufacturing them like Stryker now, Medtronics. There are many other manufacturing companies are there. The Time-ish one that started out this kind of design, maxillofacial plating or this bone flap, the cranium flap plating. You can have a design like this, or the one that you have seen, a 2-hole plates or 3-hole plates, depending on the structure. These circular type of plates are designed to cover the drill hole. If you remember, let's go back to the area where the drills were performed. As you see, the drills were performed in 3 different areas for this that type of surgery. So these you cannot cover it with a 2-hole plate. For them to cover that area, you're going to require a circular type of bone plating. Then this type of operation that we talked about is very all of these neuro cases are fascinating, but this one is uh, associated with a tumor of the pituitary gland. This type of pituitary gland tumor uh, is usually uh, happens uh, for many different reasons, and then they have one very fascinating way to take out the tumor is through the nose. The tumor is located at the pituitary areas. The stalk of the pituitary area is called sella turcica. That's the area. The sac is there, sella turcica sac. It's pretty close to the brain stem, anterior to the brain stem, and inferior to the midbrain structure. Coming out from the hypothalamus area. There's that the stalk that called the sella turcica. Now, looking at this picture, this the mid-sagittal view, you can see the axis through the nose. See the area underneath the nasal, behind the nasal cavity, sits the brain, the area of the frontal lobe, and beneath the frontal lobe, right underneath the frontal lobe, there is a way to get into go through the craniums. This is the floor of the cranium. This area that you're seeing here. Let me get a pointer. We'll show you with the pointer. This area where my pointer is, it's a plating. This area, the vault, cranium vault, they call. If you remove everything, the brain from the top, and if you look from the top to the bottom, you see there is a floor there. That floor has a one hole, which is the foramen magnum. That is where through this floor the brainstem passes down, the brainstem and the aqueduct passes. That's the only hole, is not the only hole. There are other holes there where the nerve and vertebral artery, carotid artery, they all passes. But that's my question. My reason to tell you this is because you have to imagine there is a floor, like you have a cranium at the top. Also, you have a floor. Through the floor, also you can access the brain. Going through the nose, you can access the floor of the sella turcica and make a drill hole, small drill hole, and remove this tumor beautifully. Uh, so there is a hormone overproduction is caused by this type of tumor, Cushing syndrome, or hypercorticism acromegaly. That means it's a hereditary problem with the acromegaly syndrome. That overproduction of ACTH. ACTH is a hormone produced by the pituitary gland. Ad, Adrenocorticotropic hormone. This hormone goes to the adrenal gland and starts the process of adrenal corticosteroid productions. So this hormone from here gives the signal to the rest of the body to produce corticotropic hormone. So that is why we call this corticotropic hormone. Also, it produces some other hormones, but these two are very are this hormone ACTH is a very important one. Now, to remove this tumor, they go through what they call rhinoseptal approach. There is a septum that they go through, and the nose we call it rhino. The terminology for the nose is rhino. So rhinoseptal approach, they put a nasal specula inside the nose, and then the specula advances all the way up to this bone. It's a long speculum, and they use long instruments, long drill burr to make a burr hole here, and then they use long pituitary. That's where the pituitary rongeur comes in. Those pituitary rongeurs are designed to grab this pituitary tumor here. They're long and narrow, slender. They come and they remove the tumor, and then they can also control the hemorrhage. So this process is very unique. The patient for this case are put on a semi-sitting position with a head against that headrest, the Mayfield headrest that we have. Then the incision could be through the upper gum margin, through the maxilla, and it could be through the sphenoid sinus to the sella turcica. So there are approaches that are going from the beneath the brain structure. After the excisions of this gland, the pituitary gland is done, sella turcica is reconstructed by using nasal cartilage septum or nasal packing. Uh, Sometimes they can use fat patch from the patient's thigh area, and they can put the fat to cover this hole they make in order to remove this pituitary gland. So that is what we call transsphenoidal hypophyseectomy. Transsphenoidal approach, here we can see for hypophyseectomy is done. Here is a picture of the brain. The brain, a designer view of the brain. You see the corpus callosum here, the cranial, the inferior part of the cranium vault, the floor of the cranium. The pituitary gland is there, and the tongue in respect to cartilage of the bone of the nasal area, vomer and lacrimal bone, and you can see the whole spinal cord coming down where the brainstem starts, and the cerebellum, all these to understand the approach. When they go through the anterior nasal part of the sign, that's when they go through the making incision in the mucosa of the maxilla, and they use the endotracheal tube that has a little bit of curvature, so it does not interfere with the incisions. After they do that incisions, they can use, these are kerosene sponges. These kerosene sponges can fit through the speculum. This is nasal speculum that goes to the nose here. The kerosene sponges can bite the bone, and then they can forward it with the pituitary ronger and get the pituitary tumor out of there. So that is the anterior wall of the sphenoid bone. The sinus is there, sphenoid sinus, anterior wall of the sphenoid sinus. So have a nice, careful observation of this approach. The question comes about the transsphenoidal approach. What kind of surgery is being done with this transsphenoidal approach? Then your answer would be to select pituitary tumor is removed through this approach, and the access area could be through the maxilla, mucosa of the maxilla, or through the nose by using a speculum. Craniectomy. So this is a procedure is done when they're removing bone from the skull for many reasons. They could do it for decompression of the brain. They could do it for removal of the tumor, hematoma, infection, and craniosynostosis. If you remember, craniosynostosis is the premature closure of the suture line. So all of these reasons, the craniectomy can be done. That is when they remove a part of the bone from the skull area. Subtemporal craniectomy is done in order to do trigeminal rhizotomy. Remember, there's trigeminal nerve, cranial nerve 5 causes intractable pain to the facial area, nose, lip, face, and the gum area. So to treat trigeminal neuralgia, they do subtemporal craniectomy. They go through that microvascular decompression procedure of the cranial nerve 5. And it is a microscopic procedure. So you need to have a microscope to drape and ready for this kind of procedures. The artery which is causing the problem, compression, is carefully separated from the nerve root with a nerve root retractor or as a dura separator. And then the sponge-like material like glycerol or viscid, sticky substance usually is placed between the nerve and the vessel. A trigeminal rhizotomy can also be performed by doing percutaneous incisions. That means a tiny incisions made, and the long instruments are used, and they go through a microscopic trigeminal rhizotomy. When they go through this process by making a very small incisions. The area is small, and then they can counter that area. Like, let's look at that area. Here is our trigeminal nerve. The nerve, cranial nerve, is a magnified, amplified picture here coming out, cranial nerve 5, and the artery on top of it the circle of Willis right there, the carotid artery, internal carotid artery going and branching off, and that is where the nerves comes out through the one of the foramen and of the cranium vault, and the artery sometimes causes pressure on this nerve. So the procedure is to wrap the artery, the nerve, and separate the artery with a fat cushion. And that is where that glycerol material comes into play. That material is placed right around the nerve and the artery to separate the bulging, the junction of the nerve, where trigeminal nerve becomes facial nerve and other nerves. So that relieves the pressure from the by doing the trigeminal rhizotomy. Here are some of the cranioplasty plate, and can be used by bone graft taken from the surgeon. The surgeon can take the bone graft from the patient's own thigh. Uh, the fat graft they can use, or some other areas they can take the bone graft. The cranioplasty, when they repair the defect is caused by the removal of the bone, where they can put the synthetic or titanium mesh like plate, just like here we see, to cover the whole bone flap area, where the bone has been removed. So after the bone has been removed, they can use the synthetic material like the one we see here, right on top of the dura, and it is sutured with the Neurosurgery suture or other suture of choice. And then we can put a blade on top of it, or we could just have the synthetic material works as a barrier. If you put this mesh, then we have to use self-drilling, self-tapping screws like we see here. 1, 2, 3 screws are inserted to hold the plate. So this is what we call cranioplasty. This can be done for, like we talked about, craniosynostosis, where the premature uh, uh, malformation of the suture line takes place before the growth of the cranium occurs, and that can cause a problem. So those are repaired by this cranioplasty. To repair the deficiency of the bone, if the bone is not large enough to fit the gap, this is where this can be done. Trephination is a very primitive procedure. The history shows, the medical history shows, ancient people, they learned how to do trephination to take care of multiple problems. The old anthropological the exploration shows that the cranium that were found and way back in the ancient history, those people knew how to do trephination. They used to make a borehole going through the frontal area or other areas to do multiple procedures. One of the reasons the trephination is done to stop seizure, or there could be the decompression procedure that can come along with the trephinations. So other procedure that we find that we are going to learn is this shunting. For hydrocephalus, where the enlargement of the head and becomes excess CSF to accumulate and around this area. And that CSF has to be bypassed or shunted to the other area of the body to remove it from the brain. So this hydrocephalus patient, this is a problem associated with hereditary, and these children, they go to the children's hospital and get this type of shunting procedure done. It is like a stent catheter. It is a very narrow catheter that goes placed on the goes through the cranium, like a hole you make it on the bone, and then it advances all the way up to the ventricle. The ventricle that you see this area is like this type of structure, very distinguished structure, the ventricle. We're seeing the left ventricle. We're seeing one half of the brain again, left the ventricle from the outside edge. This is the enlarged left ventricle. That's where they are putting it on the ventricle. The catheter is lodged there, advances through the sinuses of the brain, and then the suture anchored on top of the cranium, and then they tunnel the catheter out. This tunneling is not going through this inside the brain area. It goes out the outside of the cranium, then it sits outside edge of the inside edge of the scalp, but outside edge of the cranium, and they pass it along the neck area, and then they pass it down all the way up to the abdominal area. This is called ventricle and peritoneum. That's why there is going into the peritoneal cavity. So ventricular peritoneal shunt, normally known as we call it VP shunt. This whole catheter has multiple pieces. One piece, that is the area that fits the cranium area, that ends right here behind the ear. Then we put a valve there. We attach the valve to the proximal end that goes towards the head. And then we attach another catheter that comes out from the peritoneum and tunnel out through the neck area. Long tunnel is used that comes out. And then when it comes out behind the ear, there is an exposure there, little incisions made. And there, the lower part of the catheter is attached to the valve's distal end. And that valve can be accessed from outside. And it is a one-way valve, so it can let the fluid, CSF fluid, go through the valve and come inside, but nothing, the peritoneal cavity has fluid that cannot go back to the brain area. So this is how the VP shunt is done. The way the operation takes place. The patient usually are put on a supine position on the bed, and the both arm on the arm table, and then the whole areas are draped are the area where the burr hole is going to be made, and the whole body is usually covered with a sheet. It's called a split sheet. So the area of the body which are exposed here, the neck area and towards the frontal area, all the way up to the abdominal area for tunneling. So it's a long, a few split sheets are used. One U drape goes on the head area, around this area to cover. One U drape goes to the bottom area to cover, and then whole area from the scalp mid area of the scalp to the neck to the chest, all the way up to the abdominal area is exposed for surgery. So that area is prepped. So there's a long area they need to prep uh, for shunting. Surgeon usually starts with a hole here, the peritoneal cavity, and they put a catheter in there, and then they tunnel the catheter out to the neck area. This catheter is placed and lodged and coiled up, as you can see from the last picture. And here, the neck area, this catheter is pulled out by the tunneler and tagged. Means this catheter is uh, uh, exposed to the neck area incisions and ready to be attached with the head catheter. So then the surgeon goes on the head and makes a find where they're going to make incisions. They go usually right on top of the temporal lobe, and they make it small incisions with a 15 blade, and then they go through the scalp, control the bleeding with the bipolar forceps, and then they use the perforator, make a small drill to go through, or a tiny burr hole. They can use burr hole used for shunt, and then they uh, use a introducer. This introducer has a guide wire. So they use the introducer attached to the guide wire, and they pass it through the sinuses of the brain from outside of the uh, brain, uh, outside of the dura, through the brain sinuses and reaches the ventricle. And as they tap it, take the inside cannula out, or wire out, they find CSF fluid come out through the tubing. That's the part of then the catheter is lodged there, and the CSF is dripping at the end. When they find CSF through that catheter, they know that they have entered the ventricle, and that the catheter is also radiopaque. They can see it by using C-arm or the fluoroscopy. Uh, but usually they have a very good idea by looking at the marking of the catheter. They know how far this catheter is advanced inside the ventricular cavity. That's your lateral, the patient's lateral ventricle, and where the catheter is introduced all the way up to the tip, the area where the growth, the unobstructed growth has taken place and the hydrocephalus occurred. So the tip of the catheter is advanced all the way up to the front of the lateral ventricle. And they see the marking on the catheter. There's marked here, so they know how far it has been advanced. And when the catheter is, this Halter shunt catheter is named, is attached, inserted, then the CSF is dripping. At that time, they attach the valve. That's the valve that has been attached to the proximal end of the catheter. And then the catheter that is being held by a tag suture at the head and neck area, the two ends are then they're inserted to the valve. The proximal end is attached first, and then the distal end of the catheter is attached here. So that gives a shunting from the left ventricle, lateral ventricle, all the way through the Halter shunt catheter, through the valve, all the way to the peritoneal cavity. So CSF fluid comes up from the head area all the way down to the peritoneal cavity, and that's where it is absorbed. Uh, Sometime these can be, they may decide to shunt it through the ventricular atrial shunt, where they shunt the catheter in the atrium area of the heart. That is also can be done, but the ventricular peritoneal shunt is what usually commonly is done. So that is the shunt operation technique, how this catheter is done to release the pressure of the excessive CSF fluid to prevent the hydrocephalus. So this is what it looks like after the shunt is been done. As you can see, the entry point at the cranium is sutured back. The entry point at the neck area is also sutured back. It's all, the whole catheter goes underneath the skin and tunnel back from the head all the way through the neck to the peritoneal cavity. So we discussed this, how this VP shunt has been done. Now we're going to take a look at spinal procedure. This is very nice, and many of your known people may have done this procedure for disc problem or pain down the leg or radiculopathy of the arm. The one that you see on the left side is the anterior portion of the spinous process and the superior view. That means you're looking downwards towards the vertebra of the spine. So this area, the anterior part, has the large vertebra body that has cancellous bone inside. The area that causes that has the bone marrow, and it generates a lot of good material, RBCs and other macrophages and all those material. And this is where our embryogenic factor starts. This is where cell gets differentiated, and the cell comes out of the bone marrow and then is targeted to go to different area and become that. Cell goes to the blood to become blood vessels when it goes through the heart area and the other side of the body. This is a unique place, bone marrow. This is where the stem cell technology is working these days. This area is the brain, the area of the vertebral stem location. So that's anterior towards this. This is the frontal edge of our body and the body of the vertebra, and this is the posterior edge. You can feel this spinous process when you touch our back, the bony prominences that we feel by touching it. This is what we're feeling actually, spinous process. This is the tip of the bone that comes out like a T part of the bone, the edge of the tail of the T you're touching when we're touching the spinous process. Then we have a arch called vertebral arch, has two pedicles. That means two lamina, left and right, two lamina or pedicle. We can call it interchangeably either pedicle or lamina. And then we have transverse process, the process where this lamina slides, fits in. There is a very little movement there, very little movement. It's almost stuck to each other. That's the transverse process. Then we have another pedicle, lateral pedicles, left and right lateral pedicles. That is part of the body. So body is joined with the posterior aspect with the spinous process, and the lateral aspect with the transverse process by the pedicle. Pedicle, it joins the vertebrae, joins with the transverse and spinous process. A lot of time they ask this question. They ask this question, how the vertebrae body is joined to the rest of the process. This is how this is joined, so we should know that pedicle does this joining, the bridges. So this area that you see, the area, empty area, that is where our spinal cord, this structure runs. On the right, you see this structure here, that is our spinal cord that runs through that area, and the nerve roots emerges from both underneath the pedicle. So if the surgeon takes off this pedicle, transverse process, lamina, the spinous process, and round this way, cut it, remove it, what they see, this area, the spinal, the cord. So they're going to see the spinal cord from looking from this posterior area towards this. They're going to see it, spinal cord at this area. They're going to see the area, the posterior area of the spinal cord. Anterior part is still inside. You have to, in order to access the anterior part, you have to go through retroperitoneum. That means you have to go through the abdominal wall and move all the abdominal organ, like would be right around here, and then make a entry to the anterior part of the, lift up the retroperitoneal peritoneum, and then you can see the anterior part of the vertebra, the not the vertebra, the this cord structure. So there are multiple ways to approach the cord, the spinal cord. The spinal cord has layers, the same layers that we have talked about in our brain area. Dura, the meningeal layer, has 3 layers. Meninges has 3 layers. Dura, the outermost layer. Arachnoid matter is the middle layer, and then pia matter, that is the layer adjacent to the spinal cord. After that, if you go through these 3 layers, we can actually touch and reach the spinal cord. Spinal cord looks like a white large white tendon structure. It looks like a white tendon material, but if you see it cross-sectionally, you will see there is a structure like a butterfly structure there. And there is, you have posterior column, lateral column, and anterior column. These are all white matter. And the gray matter is that butterfly area. White matter means there is a nerve running around. Those are the nerves, appendages, nerves, dendrites there. And the gray matter is the nerve's actual body. That is where the neurons are. So the posterior horn, you have a butterfly's spike here, posterior horn. We have a lateral horn and anterior horn. Those are referring to different area of sensations and motor activities of our body. So you have a gray matter and then the white matter, and you have divisions like this, and you have a posterior median sulcus and central sulcus. Sulcus means the groove there, joining there, the groove of the white matter, and the gray matter comes in the junction there. That's central sulcus that runs all the way. So this sulcus area runs all the way throughout the body, throughout the head, all the way down to the lumbar 4 and 5. After that, spinal cord stops. Only the dura matter, this meningeal layer, this sac continues up to the S1. Then it become cauda equina and terminal filament. Those are the area that the spinal cord terminates into. So the side, those are the area that we have problem with. blood vessels run centrally, but the nerve root comes out, emerges from the side. The posterior aspect, we have posterior root ganglia, and then we have the ventral root or anterior root aspect comes from the anterior part of the spinal cord. So these are areas where actual nerves, like if you have a sciatic nerves, like if you imagine this is a lumbar 4, 5, and S1, then you're talking the sciatic nerve emerges from here and this goes down. And if there is a problem around this area, compression around these nerve root area, then there will be pain to the all the way up to the heel area. Not only sciatic nerve, there are other nerves like femoral nerve, the nerve that goes to the groin area, pudendal. All these branches and ganglia emerges from these two areas. The thoracic area, we have all these nerves like vagus nerve, phrenic nerves, all these nerves that we have read about, cranial and spinal nerve, they emerges from here. Cranial nerve, they emerges from the underneath the brain area that we talked about, and the spinal nerve, they emerges from the side of the spine. They actually come out through the cell body here, gray matter, and then the white matter, and then the appendages are coming out. So when they do this kind of laminectomy procedure, what they do, they expose these roots and they decompresses the disc structure. What happens is on top of each vertebrae, between each vertebrae, there is a material called nucleus pulposus. That's a soft cartilaginous material, works as a cushion in between two vertebrae body. So they, over the edge, they, because of long-term usage of the vertebrae, they sometimes merge and causes pressure on around this area to the back side of the spinal cord, and then we feel pain, excruciating pain down the leg or down the head or neck area or by the hand, wherever the whatever number or the vertebrae is associated with. So this is our structure of the spinal cord, spinal nerve, cell body, white matter and gray matter. Make this slide very useful and really carefully learn this, memorize it for your work, that you need to understand this, and also for your exam that you need to pass. So you have to memorize this. Let's see, what time is it? It's time to go eat lunch. We'll come back and join back in 30 minutes. Okay. Then we'll talk about laminectomy and posterior laminectomy procedure and other anterior cervical disc and all those good surgical procedures. Okay, let's take a lunch break.